The first question, Dr. Mikhael, is there's a listener who would like to know the significance of the immunofixation test.
So when I mentioned earlier, that's a great question, by the way, thank you. When we do what's called a serum protein electrophoresis test, so when we look for the abnormal proteins that are in the blood, we can, as it were, drill down a little bit deeper and look a little bit more carefully into what's called the immunofixation. The immunofixation gives us a little bit more detail. One, if there really is no abnormal protein left there at all. So sometimes someone's had an abnormal protein, it's going down with treatment. To prove that it's gone, we do immunofixation because it's a more careful look at that protein. The other part of immunofixation is it tells us exactly which kind of protein it is. For some patients, they have IgG or IgA or IgM, and it tells us that. So the most common use of immunofixation in myeloma is at diagnosis the first time to determine which is the abnormal protein. And then secondly, when someone has responded very well and it looks like the abnormal protein has disappeared, we get that immunofixation closer look to determine whether or not it's completely disappeared, which can put people into what we call complete remission, as opposed to being near complete remission when the immunofixation test is still positive.
Thank you, Doctor. We have a caller online. Person calling in from 907-209. You're on air. Please ask your question.
Yes, thank you very much. This is Eric Hansen in Juneau. Doctor, we keep hearing about two monoclonal antibodies that are about to be approved. And one, elotuzumab, I believe, targets the protein CD38 on myeloma cells. Is there a test now that can determine what kind of proteins are on the surface of a person's myeloma cells so that we would know which antibody to use against it?
A fantastic question, and thank you for raising the issue of monoclonal antibodies. So you are correct. There are actually several monoclonal antibodies that are being evaluated. Two that are quite likely to be approved by the FDA in the next several months. The first is elotuzumab, as you mentioned, although it's not directed against CD38. It's directed against a different marker on the surface of a cell called SLAM-F7. I know it sounds kind of aggressive, whereas there are two drugs that target the CD38 that are advanced in clinical testing, the CD38 monoclonal antibodies. One of them is called daratumumab, and the second is called isatuximab. Trust me, it takes a while to memorize all these names. But in answer directly to your question, we do have ways of testing. For example, I'm running several clinical trials with isatuximab, and for the sake of the clinical trial, we have to prove that someone is CD38 positive. Sometimes we do that by flow cytometry or different. But the reality is the overwhelming majority of myeloma patients express SLAM-F7 and CD38 on the outside of their myeloma cells. So if you know that people have that almost all myeloma cells have that, then there's less of a need to test everybody because you know that they're likely to respond because almost everybody has it. So we're not yet recommending, go check the CD38 status of the disease or the SLAM-F7 status of the disease or the newer ones that are coming, CD138 and others, for example. Right now, we know that we're developing drugs that target surface markers that are present in at least the overwhelming majority of myeloma patients.
Thank you, Doctor. We have another caller online. A person calling in from 308-381-0289. Please ask your question.
Hey, Dr. Mikhael. Most of us are familiar with the free light testing. Could you please explain the value of the heavy light test and also the availability of that test in the United States?
Thank you for that great question. So it's a little bit more involved and a bit more complex, but myeloma, as I mentioned from the very start, is complicated. It's a tough enemy to follow, and sometimes we can follow it pretty closely with the serum protein electrophoresis. Sometimes we can follow it pretty closely with a light chain test. But there are some patients where it's still a challenge, and for various reasons. And so the heavy light can be helpful, especially in situations where there can be confusing results due to different kinds of proteins in the blood. Now, this has now been an FDA-approved modality. It is becoming more accessible. Again, it's not something I routinely do in all of my patients. I'll save it for patients where there's a little bit of a diagnostic dilemma, there's a little bit of challenge in following them. So I really want to reassure most people that it tends to be a very small subset of myeloma patients that can really benefit from the heavy light, and that in general, now that it's been approved, it's a little bit more accessible. A lot of different labs will send them into places like our Mayo Medical Labs because we do so many of them here, but I suspect that over this next year or so we'll see it much more commonly available to people.
Thank you, Doctor. We'll just go forward with the questions received by email. We have our next listener writing in saying, I do not have allergies, but my labs always include tests for eosinophils. Why are these tests done, and how do eosinophils relate to multiple myeloma? And what do consistently high numbers mean?
Thanks for a great and challenging question. So the way I try and explain it to people is when we do that very first blood test I made mention of earlier, the CBC as it's called, or the complete blood count, we look at the red, white, and the rosé, as I jokingly called it, the red cells, the white cells, and the platelets. The white cells are composed of 5 subtypes of white cells. So if someone's looking at their blood work, you look at the total white blood cell count. And that total white blood cell count is made up of the 5 subsets. So there are what are called neutrophils, there are lymphocytes, and there are 3 others that are much less common, of which one is the eosinophil, as mentioned in the question. And eosinophils tend to be high in different states. They can be high in allergies, they can be high in certain infections, they can be high in certain leukemias and other blood diseases. It's a routine and standard test whenever we order a CBC to look at all the subclasses of white cells, because that can influence very much what we do. Those first 2 subsets, especially the neutrophils and the lymphocytes, give us a lot of insight as to the protection that a patient has against bacterial and viral infection. Now, interestingly, there are some myeloma patients that just chronically have a slightly elevated eosinophil count. It's hard for me to comment on it without knowing all the specifics of this individual patient. But if someone's eosinophils are persistently very elevated, then that might warrant more testing, and we can look for other things that might indicate another blood disease or an infection or an allergic condition that is maybe not fully recognized. But for the average myeloma patient, we really don't see significant abnormalities in the eosinophil count. Sometimes it can even actually just be a reflection of a drug that someone has taken and someone has a very mild reaction to it. But I would say to the person who asked the question, if it's significantly elevated repeatedly, it's probably worthwhile that your physician looks into it a little bit more, but it's not uncommon to have a slight elevation intermittently in myeloma.
Thank you, Doctor. The next question is, why is magnesium tested?
So when we do the second part of the blood test that I mentioned, the chemistry, one of the things that we like to know from the chemistry in the blood is what are the basic, what we call electrolytes, like potassium and sodium and so on, because those give us a sense of the general quality of the blood that can be affected if someone has a high calcium count or has kidney failure or something. And then there are a series of less common but still relatively important chemicals in the blood that can indicate nutritional status and other challenges. And one of them can be magnesium. I must say, we don't routinely order magnesium in all of our myeloma patients on a regular basis. We might do it initially when we're trying to assess someone's nutritional status and making sure that their chemical system is working in general. But magnesium is not something we do routinely. We might see a little bit more of it around the time of someone going through an autologous stem cell transplant because their nutritional status tends to be affected and their gut may not be absorbing things as well. And so it's not surprising that some patients require supplemental magnesium. But in the regular myeloma outpatient, magnesium is not usually repeated.
Thank you, doctor. The next question is it better to follow kappa or free light chain lab numbers or M-spike numbers to monitor relapse?
I think the right answer there is both, to be very honest, because, as I mentioned before, whichever one was an abnormal to begin with, you want to continue following. But we have individuals who have always been followed by an M-spike, but then at relapse, all of a sudden, the M-spike's not gone up, but the light chains have. We sometimes even call that light chain escape. And that's part of that evolution of the disease, as I called it, the clonal evolution that can sometimes happen. That can be a real challenge. And I know it means a fair amount of testing, but very often we want to see that change because it indicates to us that the disease is regrowing again. And let's say someone was only checking the M-spike, and on the M-spike you say, hey, well, my M-spike hasn't gone up, everything should be okay. But meanwhile, the light chains are climbing, it's affecting the body, it may cause damage to the kidneys, and all that may have been preventable if it were detected earlier. So in general, for most patients, when we follow them, we do that complete blood count, we do the chemistry, and we're doing both the serum protein electrophoresis and light chain testing and follow-up, watching for potential relapse.
Thank you, doctor. The next question is from a smoldering myeloma patient. The listener writes in my most recent lab test, my urinary protein increased significantly from a fairly stable number, while most other tests remained stable. How much of an increase or decrease in any one result should be seen as significant?
That's an extraordinary question, actually, and it's one of the things that even in our diagnostic criteria, we're very careful to note that, sometimes a single blood test can just be off. Myeloma is a complex disease, and sometimes someone's light chain just shoots up, or there's a little extra protein in the urine once, or the M-spike fluctuates a little bit. And so that's why we tend not to make any major therapeutic decision on the basis of one single blood test, unless, of course, it's an astronomically abnormal test. So in a situation where someone's being followed for smoldering disease, and all their parameters are stable, but it looks like maybe there's a little bit more protein in the urine, we go back and say, was there anything unusual about the collection? Did someone have something unusual happen to them, or were they sick around the time of the collection? And then to validate it, usually within a month, we'll repeat it a second time to see if it's genuine. Because one of the ways that smoldering myeloma can, if you will, awaken into true myeloma is through protein that can be detected in the urine. And usually it's also detected in the blood in the form of the light chain, but there are a small subset of patients where the light chains never become abnormal in the blood, but only in the urine. So it could be just a red herring, as it were, or it could genuinely be a problem. So we'd usually wait 4 weeks or so and repeat it to see if there's a consistent trend, because it's always the trend that's more important than a single test.
Thank you, doctor. I think that's a complete list of questions that we have received so far. I think Jack has one more question for you. Jack, we have time. Maybe you can ask your question.
Sure. It's more of a future question than anything else, and that is with the likelihood of antibodies like elotuzumab and daratumumab getting approved over the next 6 months. Do you expect any of these to be incorporated in the MSMART protocol for relapsed myeloma?
Oh, for sure. Absolutely. I mean, we're constantly updating MSMART because myeloma, thankfully, has more options than we had before. We had early iterations of MSMART before we had drugs like carfilzomib and pomalidomide and now panobinostat, and before long, quite likely elotuzumab, daratumumab, isatuximab, and a whole series of others that are coming. So the short answer is yes, it will influence our guidelines and therapy, suggested therapy for patients, and that's good because we want more options for our patients. Many of these drugs, when they do initially appear, will quite likely appear in the heavily relapsed setting, but I can speak even specifically of the monoclonal antibodies and the CD38 monoclonal antibodies, that there has been a lot of interest in bringing those even into the very early phases, if not the upfront phase of treatment for myeloma. So a lot of it will depend on how the FDA approves it and what indication they're given, what ultimately we recommend and goes to the NCCN onto MSMART guidelines. But I would definitely encourage people to keep abreast of this, because I think we're entering an even more exciting era for myeloma, where we're going to have more options for our patients that we hope will translate to both a better quality and quantity of life.
Well, that's great news. Thank you very much.
Thank you, Jack. Dr. Mikhael, thank you so much for sharing all this information with us. I think this has been an hour filled with useful information for our listeners. Gary, Jack, Cindy, and Matt, thank you for your participation. This talk will be made available on Cure Talks website along with its transcript. Please visit curetalks.com for details on our upcoming talks. Thank you, everyone.
Thank you.
Thank you.